Many times I hear from physicians that they know how to take care of patients, but they do not know how to transition from the care that they give and that they will give into a level of care or inpatient versus observation. So the whole purpose of this presentation is to try and make it simple and explain what some of the differences are between inpatient and observation. This presentation is based on my mantra of traditional Medicare, which is regulatory driven. The commercial payers are contractually driven and can change anything, and it can vary from hospital to hospital or provider to provider. Therefore, the goal here is to use Medicare, traditional Medicare, as the basis and as the foundation to understand. The agenda is really pretty simple. This presentation should probably take somewhere between 15 and 20 minutes of your time. So let's get started with some of the areas that will be covered. Number one, we'll talk about what is the gray area and get an understanding of the difference between inpatient and observation. Many physicians do not understand the utilization review process, so we will briefly go over that and then start going into the differences and definitions of inpatient versus observation. You probably hear frequently a second level review performed by a physician advisor, so we will spend some time explaining exactly what that is. And finally, we'll go through some of the financial and regulatory consequences of the decisions of inpatient versus observation. And again, this will have to do mainly with the Medicare, the traditional Medicare fee-for-service model. So when we talk about the gray zone are the uncertain medical necessity cases. And medical necessity is something that you hear all the time. So there are two statuses, if you will, inpatient and outpatient. We'll talk a little bit about what observation is in a subsequent slide. But there are two circles, inpatient and outpatient. And these two circles do meet in the middle and overlap. That is called the gray zone. So there are certain cases that are inpatient and will always be inpatient after appropriate review. And there are those situations that will always be outpatient after appropriate review. Some of the inpatients, the definite inpatients, are the inpatient only listed surgery. And those cases that do meet inpatient criteria, which we'll talk about in a little bit. And then there are those that are definitely outpatient, such as getting lab work, a dialysis, and even a simple blood transfusion. But the gray zone is that overlapping area. They are cases that require individual assessment due to unclear medical necessity. Revenue and compliance risks exist in that situation. And typically we see the gray zone being the symptom DRGs, such as TIAs, CVAs, syncope and collapse, chest pain, and more. So I've already mentioned a utilization review process, and what exactly is a recommended utilization review process? And in its simplest forms, there is an initial order and medical necessity expectation, and there must be an order at the time of the patient's encounter as to whether they are going to be inpatient or observation. Now, physicians say to me, I'm not sure which one to choose, and I always say choose what you think is clinically the best based on what you see and how the patient is presenting, and then allow the utilization review process to take place to see whether it will qualify or whether it needs to be changed. And what happens shortly after the placement in the hospital is that the utilization review specialists apply criteria. Now that may be Interqual or it may be Milliman. It depends upon what they have available and what the contracts are with some of the payers. But they will apply inpatient criteria. Now, the way it's supposed to go is that if that patient does not meet inpatient criteria, they could do several things. They can go and talk to the physician to see if they can get more information. And if they still can't, to make a justifiable judgment, then they will refer it to a physician advisor for a second level review. Now, mind you that case managers, utilization review nurses, are not allowed to make that final determination for what that level of care is. They are not doctors, and Medicare clearly states, in no case may a non-physician make the final determination that a patient's stay in the hospital is medically necessary. We will go over subsequently what that second level review by a physician advisor actually is. Therefore, what is the process in your facility? Well, first of all, as I already mentioned, the first level review will utilize criteria such as interqual or MCG, which is Milliman, and in some situations there are other criteria that are used. Second level review, who does it? Usually it is done by an attending, although that attending cannot be involved in the care of the patient, have any financial involvement with the care of that patient, or a PA, one that is other than you. There are some situations where PAs are also hospitalists and they alternate, but they cannot do a second level review on a case that they are involved with. Now, there is one level of care, and that is outpatient, which has not been shown in some of the previous slides, but it's important to understand what an outpatient is. So a hospital outpatient is a person who has not been admitted by the hospital as an inpatient, but is registered on the hospital records as an outpatient and receives services from the hospital or a critical access hospital. Where the patient uses the category day patient, which is an individual who receives hospital services during the day and is not expected to be lodged in the hospital at midnight, the individual is considered an outpatient. And lastly, a hospital outpatient encounter is a direct personal contact between a patient and a physician or other person who is authorized by state licensure law and, if applicable, by hospital or critical access staff bylaws. Typically that would be a physician's assistant or a nurse practitioner, but they must be certified in order to furnish hospital services for diagnosis or treatment of the patient. Therefore, what exactly is observation? Well, let's start off first with, is observation a status? And the answer is clearly no. In the Medicare world, there are two statuses, and actually this transitions over to the commercial payer world too, including the Medicare Advantage programs. But in the Medicare world, there's inpatient, which is Part A, and there's outpatient, which is Part B. Observation is not a status, but it is a level of care. Observation, by definition, is a service that is provided to an outpatient in a hospital bed. So the definition of observation, according to the Medicare Benefit Policy Manual, is, and I laugh at this, observation care is a well-defined set of specific clinically appropriate services, and what I laugh at is the fact that it's actually not really well-defined, but which includes ongoing short-term treatment, assessment, and reassessment before a decision can be made regarding whether patients will require further treatment as hospital inpatients or if they are able to be discharged from the hospital. It is important to remember, as physicians with patients in observation, visiting them just once a day is not sufficient. When we talk about assessment and reassessment, these patients should be reassessed a couple times a day, which will require a physician visit. Observation services are commonly ordered for patients who present to the emergency department and who then require a significant period of treatment or monitoring in order to make a decision regarding their admission or discharge. And I think those two words, treatment and monitoring, are very important in trying to make the decision whether it's inpatient or observation. Now, I previously mentioned a couple times the use of screening tools such as interqual or Milliman, and the Medicare Program Integrity Manual definition requires that contractor review staff use a screening tool as part of their medical review process for inpatient hospital claims. CMS does not require that the contractor use specific criteria or endorse any particular brand of screening guidelines. CMS contractors are not required to pay a claim even if screening criteria indicate inpatient admission is appropriate. Conversely, CMS contractors are not required to automatically deny a claim that does not meet the admission guidelines of a screening tool. So as mentioned several times, a second level review, what exactly is that? So UR applies inpatient non-physician criteria. That's important to remember, that the criteria that are used are non-physician criteria. They apply these criteria regardless of the initial order for level of care, minus artificial intelligence, which sometimes comes into play here, but not as frequently as thought to exist right now. If a patient meets inpatient criteria, they can be certified as an inpatient, and most of the time it will be defendable. What happens or should happen if inpatient criteria are not met? And I think it's important to talk about inpatient criteria versus observation criteria. Inpatient criteria should always be applied first, the highest bar. If they don't meet, then we can go on to the second level review. Observation criteria are tools of the commercial payer and really should not come into play when looking at patients. In addition, UR cannot use their judgment or past experience with similar cases. They need to talk with the attending to get more information or refer the case to the physician advisor for the clinical review. The physician advisor applies clinical criteria, evidence-based medical principles, not interqual or Milliman, although sometimes they are forced to do that with the commercial payers. The physician advisor can reach out to the attending for additional information or conversation, and by regulation, the attending physician must be involved. Based on documentation, clinical principles, conversations, and chart review, the physician advisor will make a recommendation for level of care. Now, mind you, it is a recommendation, not a determination. The final decision rests with the attending whether to agree or disagree with this recommendation. In Medicare, if it is inpatient, change to observation, something called Condition Code 44 is invoked, but this will not be discussed in this presentation. Therefore, those are the essentials for observation. Now, when talking about inpatient, this information is going to come from the Medicare Benefit Policy Manual, Chapter 1, Inpatient. Now, should you decide, and I wouldn't fault you if you didn't, you can go to the internet and download Chapter 1 of the Medicare Benefit Policy Manual. That being said, according to them, inpatient is a person who has been admitted to the hospital for bed occupancy for purposes of receiving inpatient hospital services. Generally, a patient is considered an inpatient if formally admitted as an inpatient, and we will talk about that exception in a moment, but with the expectation that he or she will require hospital care that is expected to span at least 2 midnights, then occupy a bed even though it later develops that the patient can be discharged or transferred to another hospital and not actually use a hospital bed. Now, the reference of an expectation of 2 midnights comes from the 2-midnight rule, and that will be discussed further in subsequent presentation slides. So here is the exception. Prior to, I think it was 2016, actually 2019, an inpatient order was considered a condition of payment. And if the inpatient order wasn't there, then that case would be denied. But Medicare wanted to get to the point of not having all these denials based on a technical formality. Therefore, even though it took them 4 years to realize that their contractors were denying admission solely because the order wasn't present or authenticated prior to discharge, they realized that that was happening and then formally removed the admission order as a condition of payment. a change that became effective on October 1st, 2018 in the 2019 Inpatient Prospective Payment System Final Rule. That you really don't need to know a lot about what the IPPS is. In the 2019 IPPS proposed rule released in April, CMS stated, "It was not our intent when we finalized the admission order documentation requirements that they should by themselves lead to the denial of a payment for otherwise medically reasonable and necessary inpatient stays." Now, that's not saying that you don't need the inpatient order. It's saying that if it's not there, inference can be made that an inpatient level of care was considered necessary based on the documentation. And again, what that does is ensure the fact how important documentation actually is. But let's continue that a little bit. The physician or other practitioner responsible for a patient's care at the hospital is also responsible for deciding whether the patient should be admitted as an inpatient. As I said before, it is the final decision on the part of the attending as to what the level of care will be. Physicians should use the expectation of the patient to require hospital care that spans at least 2 midnights as a period as a benchmark. They should order admission for patients who are expected to require a hospital stay that crosses 2 midnights and the medical record supports that reasonable expectation. Again, it depends upon the documentation. However, the decision to admit a patient is a complex medical judgment when it could be made only after the physician has considered a number of factors, including the patient's medical history and current medical needs, the types of facilities available to inpatients and to outpatients, the hospital's bylaws and admission policies, and the relative appropriateness of treatment in each setting. Now, this gets to be very important, especially for documentation. So the factors to be considered when making the decision to admit should include such things as the severity of signs and symptoms exhibited by the patient. That's the acuity. Secondly is the medical predictability of something adverse happening to the patient. Now that's how physicians think. When we admit a patient, we think about what can go wrong, and the other part of that is how predictable are those concerns that something adverse can happen. Those two first bullet points determine the acuity of the patient. If the acuity of the patient is not well defined, then the third bullet point becomes a problem. The need for diagnostic studies that appropriately are outpatient services, for example, their performance does not ordinarily require the patient to remain at the facility for 24 hours or more, to assist in assessing whether the patient should be admitted. Now that's important because, as this said, these are outpatient services, but if the acuity of the patient is well defined, then that allows the third bullet point to take effect. And lastly, the availability of diagnostic procedures at the time, when, and at the location where the patient presents. So as the final thought in this presentation, let's talk about the 2 midnight rule, which actually came from 2014, the final rule of the Inpatient Prospective Payment System moving forward. Now there are 2 parts to the 2 midnight rule. There is the benchmark and the presumption. Let's talk about the presumption first. The presumption of 2 midnights states that under the 2 midnight presumption, inpatient hospital claims with lengths of stay greater than 2 midnights after formal admission following the order will be presumed generally appropriate for Part A payment and will not be the focus of medical review efforts, absent evidence of systematic gaming, abuse, or delays in the provision of care. Now, 2 points to be made here. Number 1, following the order, and as stated in a previous slide, that order is no longer a condition of payment. But the other thing that's important is that the absent evidence of systematic gaming, abuse, or delays in the provision of care, if any of these are found to be present, then the 2 midnight rule, the presumption, does not apply and will make these cases subject to review or audit. The next one is the benchmark of 2 midnights. What that is the decision to admit the beneficiary should be based on the cumulative time spent at the hospital, beginning with the initial outpatient service. In other words, if the physician makes a decision to admit after the beneficiary arrived at the hospital and began receiving services, he or she should consider the time already spent receiving those services in estimating the beneficiary's total expected length of stay. Now, it's not as important for you as the attending to totally understand this, and that is one of the reasons why you have utilization review and a physician advisor. But in essence, this is saying that a patient could spend one night in observation and one night as inpatient, but having crossed 2 midnights certified for an inpatient level of care. Last, I want to talk about the financial and regulatory consequences of all of this information that's been presented to you. So if we look at why is getting patient status correct so important? And it really is. And keep in mind that an order for level of care cannot be placed after discharge. So if we look at the inpatient side, why is it important to get it correct? Well, you want to submit a compliant claim. There is something called the False Claims Act, which states that if you knowingly submit a false claim, that you could be subject to investigation and penalties. There's also the risks of audits, which can result in loss of revenue. On the outpatient side, the effects are a little bit different, but it has to do with length of stay, mortality rates, because they are based on inpatient level of care. SNF qualification, as you know, 3 qualified inpatient days in order to get coverage for a skilled nursing facility. And lastly, we're going to talk a little bit about the financial burden on the part of the Medicare beneficiary, because it's all about getting it right. Now, a question that I raise many times is that supposing you have a patient that is admitted by the night hospitalist, and in the morning the covering hospitalist comes in and says to themselves, this patient should never have been admitted as an inpatient, I'm going to change them to observation. The question is, do they have the right to do that? And the answer very clearly is no. They do not have the right. That patient must be allowed the benefit of having a proper utilization review to determine the level of care and whether it qualifies or not. So these are the 2023 inpatient hospital deductibles per benefit period. Now, what is a benefit period? A benefit period begins the day you are admitted to a hospital as an inpatient or to a skilled nursing facility, and ends the day you have been out of the hospital or skilled nursing facility for 60 days in a row. After you meet your deductible, original Medicare pays in full for days 1 through 60 that are while you are in the hospital. That's a key factor. Now, if a patient is discharged but readmitted during that 60-day period, they do not have to pay that deductible. But if it is after that 60-day period, the benefit period is over and another deductible will be charged. So here are the statistics. Part A, the deductible is $1,600 for each benefit period. For days 1 through 60, as already mentioned, there's a $0 co-insurance for each benefit period. For days 61 to 90, there is a $400 co-insurance per day of each benefit period, and everything is covered beyond that $400. Days 91 and beyond, there is an $800 co-insurance for each lifetime reserve day. So days 91 to 150 are the lifetime reserves. And those 60 days, once they get used up, they're gone and can never be used again. Beyond lifetime reserve days, all costs are placed on the Medicare beneficiary. Luckily, there are very few patients that end up staying in the hospital that long a period of time. Part B, which is outpatient, is a $226 annual deductible. It has nothing to do with the benefit period. But here's the factor. Even though they're covered, there's a 20% copay for all covered medical services, and there is a 100% cost for all non-covered services. That is why a patient placed in observation can have a potentially higher financial burden if they were appropriate for an inpatient level of care. And then to the left, you could see what the base observation payment is, and that is just provided for informational reasons and not something that you necessarily need to know. In conclusion, if you have any questions or comments, there's my contact information, and feel free to reach out to me at any point in time. Thanks. Have a great day.